All right, good afternoon. I have the pleasure of introducing our Grand Round speaker. She has no financial interest conflict that we are aware of. Nosheen Ranjbar is currently a chief resident at the University of Arizona Department of Psychiatry. Her focus is on integrative psychiatry and mind-body medicine, and she's currently receiving training through the Center for Mind-Body Medicine. She's been facilitating mind-body medicine skills groups in our outpatient clinic since July, and she has also been involved in initiating a new program of mind-body medicine outreach for Native American populations in the Pine Ridge Reservation in South Dakota. Her main interest is learning about and working with trauma healing. She's originally from Iran and moved to the U.S. at age 12. She completed her medical training at the University of Virginia, and following some training in family medicine and integrative medicine, and a few years of clinical research on brain neuroplasticity at Yale University, she joined us in the Department of Psychiatry a few years ago. Upon graduation in June 2012, she will be pursuing a child and adolescent fellowship at the Children's Hospital in Boston. Her future goal is to pursue mind-body medicine with work with children and youth, and eventually help create an integrative models of trauma healing for special populations, including Native Americans and refugees. Please welcome Nosheen Ranjbar.
Thank you, Dr. Heron, and all of you for joining us this afternoon. Are the lights going to get dimmed? So it is my honor to be here and to speak regarding something that has become quite dear to my heart, which is studying trauma spectrum disorders and various modalities that are being looked at as possible treatment modalities for this spectrum of diseases that have been quite disabling and causing a lot of distress for a lot of children, youth, and adults. I'm going to start with a case summary of a gentleman that I met about a year ago. Daniel is a 57-year-old Vietnam veteran with a diagnosis of chronic severe post-traumatic stress disorder. He struggled with flashbacks, nightmares, and hypervigilance for decades. When asked about his most troubling symptoms, he stated, "The spirit of a man whom I killed in battle continues to follow me around." He mentioned that the guilt he felt was even more pronounced as he found out that the man had been a shamanic healer. He described the experience as terrifying, unbearable, and making his life not worth living. He had tried multiple treatments, including medications, years of individual and group therapy through the VA hospital, all unfortunately with minimal relief. He continued to struggle with his disability and significantly compromised functioning. Daniel reported that after many years, he was invited to participate in a Native American healing ceremony facilitated by a Lakota elder and medicine man. He decided to attend. He reported that during the ceremony, he noticed that, as usual, the ghost of the dead shaman accompanied him. During the ceremony, the medicine man invited those present to think of someone they would like to ask forgiveness from and someone they would like to forgive. It was an easy decision for Daniel, the dead shaman. As the drumbeat and chanting by the musicians continued, Daniel sat on the floor, tears flowing down his face, and he communed with the image of the dead shaman. He sobbed as he asked for forgiveness for what he had done, and in turn forgave the ghost that had been haunting him over the years. The medicine man went around smudging the participants with sage, honoring the intense experience they were having. I met Daniel at a Lakota seminar years later. At one point, the participants were asked if anyone had a testimony to share. Daniel shared the following. Something shifted for me during that ceremony. The shaman's ghost was there with me, but I noticed it was as if he was also participating in the ceremony instead of haunting me. During the forgiveness and cleansing ritual, I bowed before him, Daniel said, and asked him for forgiveness as tears rolled down my face. It was as if his eyes and face softened, slowly transformed from that terrifying ghost who had followed me everywhere for years. Then the ceremony ended. Daniel continued, "My symptoms have improved considerably. I'm able to work and function now in a way I never thought possible. I've been able to connect with my family and make friends again." Someone from the audience asked Daniel if the shaman's ghost still followed him. Daniel smiled and said, "Yes, but he is now my best friend." So with that, I'd like to spend a little bit of time talking about trauma, its definition, psychoneuroimmunology, the notion of trauma spectrum disorders, current views, an overview of treatment modalities, and then spend some time on the notion of ceremony and ritual, its definition, its historical perspectives, the varieties that exist in the world, and then its role in the treatment of trauma spectrum disorders, some research findings thus far, and remaining questions and further research. Trauma comes from the Latin word meaning wound. In some instances, it can be referring to a physical wound, and in this instance, we're talking about psychological wounds. The historical definition is that trauma is an extremely stressful experience, bringing up vehement emotions, overwhelming the ability of the individual to use normal coping mechanisms to adapt. And it usually disrupts the frame of reference if not resolved for that person. So situations they come to that normally would not be completely stressful and overwhelming become so because of this disruption of the frame of reference. And then there's an evolving definition for the word trauma, and this partly comes from the work of Dr. Peter Skaer, who wrote the book, The Trauma Spectrum, we'll talk about in a little bit. But he defines trauma as a continuum of variably negative life events occurring over a lifespan, which can shape every aspect of an individual's or a community's existence. Here's just a little copy of his book, The Trauma Spectrum, which I highly recommend. Dr. Skaer is a neurologist who spent years working with patients who had chronic pain disorders resulting from car crashes and various traumatic incidents, and he looked at the psychological effect of trauma as well as its physical sequelae. What he talks about is that the energy of hyperarousal that gets hyped up and stored in the body as a result of trauma must be used up or discharged. Otherwise, it stays trapped in the nervous system and as cellular memory, creating the potential for ongoing symptoms of physical and psychological nature for years to come. Unresolved trauma can usually really define the way people organize their subsequent perceptions about the world around them, people they meet, experiences that they have. It can actually cause an identity and an existential crisis where the person doesn't know who they are, what they believe in, what's safe, what's not safe. There are several types of traumas. There are macro traumas, which are historically defined as trauma. That's war, severe natural disasters, someone getting raped, an organized crime, a disastrous airplane crash. But then there are micro traumas. There are car accidents, risky medical interventions, childhood abuse, neglect, social discrimination, prejudice, poverty, loss or betrayal from a significant person in our lives. At a completely different level of complexity is what we call historical or multi-generational trauma, traumas that affect the life and the ability of a community to survive, to live, and to feel fulfilled and healthy. And some examples of those are genocides with the Native Americans in the Americas, what has happened in Bosnia, Kosovo, the Holocaust, Cambodia, Middle East, Zimbabwe, really any part of the world you can find evidences of historical trauma that are still affecting the way people live, the way people believe, the way people act towards themselves and towards others. Let's talk a little bit about how, as humans, we respond to trauma. So there's a reflexive survival response, which we all know quite a bit about, that is present in animals as well as humans. And there are several forms of this reflexive survival. The first one I'd like to just focus on briefly is the fight or flight response, which we're familiar with through the sympathomimetic activity, the production of epinephrine, the norepinephrine, production of cortisol in the system, basically revving up the body to either fight against whatever is harming us or flight from it. There's increased respiration, heart rate, the movement of blood away from the skin to the large muscles that are needed for running away or fighting back. And again, it allows for immediate survival. And then the other response that is evolutionarily recognized is what we call the freeze response or the immobility response. This response competes with the fight or flight, but it's also the most primitive response. It is a result of overwhelming parasympathetic vagal activity, where the heart rate slows down incredibly, respiration ceases, the blood pressure drops. This is where the person is going into shock because their emotions are so overwhelmed from what's happening to them that they almost don't feel anything. The reason they don't feel anything is that high doses of endorphins, extremely high potency painkillers, get released in the body as a result of this freeze response, as well as acetylcholine that further inhibit movement. And in the case of animals, this what makes the killing of the animal kind of a pain-free death experience. That's how evolution has kind of made this happen. And what is known is that higher states of baseline anxiety and inescapable threat environments predispose animals and humans to this freeze response. So the more stressed, the less aware, the less mindful, the less relaxed we are when something bad happens to us, it is more likely that we will go into this shock or general shutdown mode. And it is quite a common response in children due to their helplessness. They don't have the resources adults have to run away or to fight back a lot of times when bad things happen to them. And so a lot of them go into this shutdown mode. A lot of this work comes from the work of Dr. Peter Levine and his book, Waking the Tiger, in 2006, I believe. Dr. Levine actually lived in the wild for a long time in the wilderness and studied animals, wild animals, and how they respond to stress. He realized that prey animals that tend to survive in the wild display interesting energy discharge movements like trembling, shuddering, perspiring, followed by deep breathing and shaking themselves off, and eventually running off after a traumatic thing happens to them. What's interesting is that as babies, we come to the world with some of these responses. So the baby cries when a need is not being met. It screams when it's unhappy. It shakes when it's scared. But what's coming to be known through research is that a lot of us as humans, we tend to lose a lot of those natural body abilities to release this type of stress. And a lot of times it's because of societal norms and shame. So we're told, it's not okay to cry because you have to be a big boy, or it's not okay to scream, or you better not yawn, or you better not shake, basically because of the structure of our society. But what happens is that as we grow older, and if we live in environments where it's not okay to express ourselves in these ways, then we tend to actually suffer from not having this natural ability to release stress. So some of those modes of energy discharge in humans that we're talking about are things like sweating, breathing, deep breathing, crying, talking, writing, vocalizing, and various forms of movement and other types of self-expression like the arts. The third response I'd like to touch base on trauma, to trauma, is what we call the tend and befriend response. This is a response that historically is thought of as the mother-child relationship, where the environment is oxytocin mediated, which is a hormone that's produced both in women and men, and it's produced much more at times when true bonding is happening. So this is how the baby, even though it doesn't really know its mother cognitively yet, through the oxytocin feels the energy of belonging and being wanted or not. The tend and befriend response is also parasympathetic nervous system mediated. It tends to restore a sense of safety in the face of danger. So the child who's running around for the first time and discovers something really scary and sees mom who is emotionally available, and the child runs to the mom and says, "Mom, help me," there is oxytocin being produced, allowing the child to feel safe in response to whatever the stressor is, cry or scream or do whatever he or she needs to do to relieve that stress, and basically go back to a wholesome nervous system and ability to react to the next stressor. And so a parent, a caregiver, a friend, a therapist, and for many of us, social and spiritual communities can actually help provide that tend and befriend response, where it's okay to feel whatever we're feeling in those environments. We're not judged, we're not yelled at, and we're not punished for being who we are. Now, the way this links us to our talk about ceremony and ritual is that ceremony and ritual have been used by indigenous communities for thousands of years as powerful means to discharge bottled up emotions for people in a structured, safe setting. And that's how a lot of communities and humans have survived. Now, a little bit about trauma psychobiology. Just like the sympathetic nervous system is kind of like the gas pedal in the car where everything revs up and we get really hyper vigilant and excited and ready to fight or flight, the parasympathetic system acts as the brakes, if we were looking at a car analogy. And the parasympathetic system is really there to reestablish that sense of safety, a relaxation in the mind and body even after something horrible has happened and we've become really revved up. It's also responsible for getting us back to connection to ourselves, who we are, what our strengths are, our connection to nature, to other people, a sense of purpose and meaning in life. And the resolution of trauma is really dependent on multiple pre- and post-trauma factors that make up who we are before the trauma, during the trauma, how we cope with it, and then how we are able to resolve the trauma or not. And the notion of resilience has been written about and studied for a while. There are something like 33 factors from a genetic, environmental, nutritional, biological, social, emotional, and spiritual factors that make up how resilient we are at any given point in our lives. In his book, Dr. Stephen Porges, The Polyvagal Theory, the Neurophysiological Foundations of Emotions, Attachment, Communication, and Self-Regulation, he talks about the metaphor of safety and the different parts of the vagus nerve and vagal system that really help moderate how we respond to stressful experiences. So he talks about the ventral vagal system that is responsible for the safety mode. So this is where we do our best. This is where we have an optimal arousal level. We are able to be restful and do what we do well and enjoy what we're doing. And again, it's part of the parasympathetic ventral vagal system. It is what allows us to healthily engage in social activities without being mistrustful or scared of who we're interacting with and running away from them. And it's very much connected to our ability to have eye contact, our facial expressions, our vocalization, and as you can imagine, a lot of this is unconscious neurological activity. So even before we recognize who it is we're talking to, we might feel tension in our shoulders when we enter a room, or feel stressed and we don't even know where that's coming from. And then there's kind of the yellow zone, which is the danger mode of the nervous system, which is sympathetic mediated. It's all about hyperarousal, the increase in the heart rate and the various physiological activities of the body, what we call the fight or flight system, and it can be as bad as a dissociated rage and panic, where we're just out of control and we don't even know what it is we're trying to fight or flight, but it's just unconsciously unbearable and we're going at it. And the third mode that Dr. Porges talks about is this freeze response that we just mentioned a little earlier, the hypoarousal, decreased heart rate, decreased respirations, and he talks about this being mediated by the dorsal vagal system and responsible for this immobilization response, the deer in the headlights, and really a dissociated collapse of the body and the mind, going into shock when something horrendously awful is happening. He talks about the moderate arousal there in the middle being the normal mode of pleasant functioning, where psychotherapy is able to work the best, where the person is aroused enough or aware enough to be able to cognitively participate in conversation and processing, where the above area is where the sympathetic hyperarousal is so extreme that really the person wouldn't be able to do a whole lot of processing because they're just way out of control in their fight or flight mode. Or the bottom, where the arousal is so low and the person is so in shock from whatever they have dealt with in depression or hopelessness or disgust or shame, where you could be talking to them and trying to get them to talk for weeks or hours or months or years and not have a lot of success because their arousal is not optimal for the type of therapy that's being offered. The social engagement system, which I find fascinating, is how the cranial nerves that are responsible for our ability to deal with our environment are really being constantly affected by our emotions, what's happening in the brainstem, whether we're able to cognitively process that in the cortex or not, and then feeding back into our muscles of facial expression, from what we hear, how we use our facial muscles, how we're able to vocalize something or not, whether we're able to turn our head or, go into kind of the stare of shock of looking straight ahead and not being able to make eye contact, and then what happens to our breathing and to our heart from a standpoint of ability to relax or not. DeBellis in 1999 looked at how the corpus callosum develops at an accelerated rate between 6 months and 3 years of age, and it continues to develop into the 20s. So the limbic system, which is responsible for our emotional responses and emotional awareness, the prefrontal cortex, which has to do with planned behavior, memory, emotional memory, really those developments continue into people's 20s. So events that are traumatic in whatever way, basically throughout a child's life and into adulthood, can really have a bearing on how that person is able to respond to other stressors and how that person is able to function. And a lot of this is mediated by all the various hormones that we talked about, for example, the cortisol and the dopamine or epinephrine and epinephrine. You can see the amygdala, and basically we won't spend a lot of time in this because of the interest of time, but really there's response back and forth going to the adrenal gland through the production of cortisol and to the various other endocrine cells of the body as a response to everything we think and feel as a result of a stressor. Just a couple points on this image that talks about resilience, really, and how that impacts trauma exposure and how we deal with trauma. So our ability to cope, the type of coping that we use, the effectiveness of our coping skills, and our flexibility to be able to use the right coping skill is really mediated by personal, social, and cultural factors, from prior history of trauma, genetically increased stress reactivity, and many other factors that contribute to that coping response. And so that can have a bearing on what kind of defense mechanisms we use when something bad happens, whether we go into avoidance, disengagement, or do we have a social support? Are we able to seek social support? If social support is there, are we able to perceive that it's truly there? And so this diagram shows that the trauma exposure and how we the story we tell ourselves about what just happened to us basically is a result of what defense mechanisms we have in place, how our coping mechanisms are working, and what our social support seeking and response is like. And so that initial appraisal can be pretty negative, thinking about something as being a threat, danger, harm, and being totally uncontrollable and basically putting us into shock potentially, which is then responsible how we feel and how we behave in our response in that peri-traumatic phase, which is all mediated by the neuroendocrine response, the HPA axis dysregulation, and the sympathetic nervous system hyperactivity. And if the right amount of social support, being able to seek it, perceive it, is not available and our coping mechanisms are subpar, then we are much more likely to develop post-traumatic stress disorder, depression, addictions, etc., as a result of what we have faced. So when there is unresolved traumatic stress, it can result in post-traumatic stress disorder. So the definition we have from DSM-4, the hypervigilance, the nightmares, the flashbacks. And Dr. Horowitz looked at this from an interesting perspective. He saw it as a biphasic model where basically the individual is shifting between emotional numbing and emotional flooding. Either they are completely unable to respond to their environment, or they respond with panic and totally freaking out. And this emotional dysregulation is then thought to lower the person's resiliency to mental and physical illness. So some of the emotional difficulties as a result may be symptoms of depression, anxiety, addictions, and it may lead to autoimmune disorders, chronic fatigue syndrome, endocrine disorders, fibromyalgia, IBS, irritable bowel syndrome, myofascial pain, sleep disordered breathing, and the list goes on. I think we already covered this optimum arousal, hyperarousal, and numbing, so I'll just continue with this. And what's interesting about the interplay between psychological stress and brain injury, physical brain injury, is that there are a lot of symptoms that overlap. So when something physically harmful happens to our brain, or to us psychologically, in a TBI case, there's a headache and nausea, vomiting, sensitivity to light or noise or vision problems. And then PTSD, we have the symptoms that we're very familiar with. And then there are symptoms that overlap in the psychological as well as the physical aspects of injury. And those are ongoing fatigue, irritability, insomnia, depression, cognitive deficits. And when trauma is not resolved, it can really shape all aspects of existence. Again, based on Dr. Scare's work, it can really mold our personality, our choice of mate, our profession, our clothes, our appetite, pet peeves, social behaviors, posture, and most specifically, our states of physical and mental health and disease. The current treatment modalities for post-traumatic stress disorder and other trauma-mediated disorders are medications. So we have the antidepressants, anxiolytics, antipsychotics, neuroleptics, alpha blockers, which are used depending on what symptoms of the trauma are the most bothersome. And then there's psychotherapy. We have exposure therapy, cognitive behavioral therapy, psychodynamic therapy, group therapy, and EMDR, eye movement desensitization and reprocessing, that are all used for various forms of trauma-mediated illness. In addition, there's a growing body of evidence about the use of mind-body medicine skills groups in the treatment of trauma. These are groups in which the facilitator creates a space for the participants to teach them ways to enhance their capacity for self-care, to help them become more self-aware, increase their coping skills, and reduce their stress. Basically, improve their vagal tone and parasympathetic nervous system's ability to moderate how they respond to stressors. It is a model of empowerment to enhance functioning for the individual. And the techniques that are used are very simple techniques that have been around for thousands of years. And all of them are physiological ways of, connected to physiological ways of reducing stress. And they have to do with deep breathing, biofeedback, use of meditation and mindfulness, guided imagery, mindful eating, journaling, drawing, movement, and ceremony and ritual. We're going to focus on ceremony and ritual. Ceremony is defined as an event of ritual significance performed on a special occasion, may have physical and verbal components. Examples are ceremonies we have when someone's born, for an initiation, when there's puberty starting, adulthood, graduation, marriage, retirement, death, burial, change of seasons, for spiritual reasons. There are many reasons to have ceremonies. A ritual is defined as a set of actions performed mainly for their symbolic value, usually prescribed by a religion or traditions of a community. There are many examples of ceremony and ritual around the world. We will talk a little bit about the Native American rituals, some examples being the sun dance, powwow, sweat lodge, uwipi, wiping of tears, giveaway, homecoming ceremony. The African culture has a lot of different types of ceremony involving drum and dance. The Sufi community, you might be familiar with the whirling dervishes. South Americans, the Peruvian despacho, and various religious ceremonies from Christian, Islamic, Hindu, Buddhist, Jewish, Zoroastrian, basically any religious tradition. Here's an example of a Native American man outside of a sweat lodge preparing his drum. This is a sunrise ceremony in the native ways that honors the start of a marriage, a couple coming together. Some beautiful pictures of an African drum and dance. That's the Sufi tradition. And this is an example of a Peruvian despacho ceremony in which items of symbolic significance are put together specifically for an event, whether it be a birth or a funeral or a marriage or some other event of important significance. The purpose of ceremony and ritual is, there are many. There's satisfaction of spiritual and emotional needs of an individual or a community, to facilitate adaptation to change. So when a baby is born, not only the life of the baby has started and is significant, but everyone around the baby is affected and stressed out and excited and needs to adapt. So it would facilitate that change, for example, for the whole community. To strengthen social bonds, to promote social and moral education for children and the rest of the community, to help people practice being respectful and reverent towards a symbol or a belief system. And the other purpose is for an individual to obtain acceptance or approval for a transition. For example, a couple who are getting married or something like that. The historical significance of ceremony and ritual is that it has really helped maintain social structure and norms for thousands of years. It has helped individuals and communities manage their anxiety generated by strains of change. And the survival of the community has really been facilitated by having some kind of external symbol, a space to go to, something that allows for the expression of whatever emotions are coming up about that change. And it takes a community or a person from a chaotic way of feeling to a structure. Joseph Campbell talks about the importance of myth and metaphor and symbols in communities and individuals surviving and having meaning and purpose in their lives. And this is specifically from a Native American perspective, but ceremonies are really healing ceremonies for healing spaces for detoxification, for purification and healing. And the three main components of that we see a lot of is the use of breathing, the respiration, perspiration, whether it's in a sweat lodge or through dancing or movement, and tears, being able to express sadness or frustration or whatever is coming up through that physiological mechanism. Just a little picture of some sage that a lot of the native communities use for the purification and ceremony purposes. Now, we're finally coming to the significance of ceremony and ritual for healing from trauma and trauma spectrum disorders. Historically, what ceremony and ritual has allowed people to do is to review whatever has happened to them, whatever change, whatever terrifying event, whatever stressful circumstance, to review that in a safe, delineated space and setting. And one of the research papers I read talked about something that makes a lot of sense to me anyway. He talks about the aesthetic distance that's created in a ceremony space, where it really is creating an intermediate level of arousal, whether it's that trance state that happens when the dervishes are whirling, or whether it's in the sweat lodge where you're perspiring and you're breathing very rapidly and you're kind of in that trance mode, trance state. But it creates, and because of its artistic, colorful, musical environment, it helps the individual who's had something difficult happen to them be able to step outside of themselves, to see the beauty of a space that's been created and what's going on. And it's thought to be really optimal for adaptation, for catharsis, and for integration, because when we're really tense and wired up about something that's happened to us, it's very hard to integrate it cognitively into a story that is healthy and makes sense and doesn't handicap us. But when we are finally able to relax and let out the anger or the frustration or the exhaustion or the sadness, then finally the integration can happen a lot more easily. And what ceremonies do from this aesthetic distance is to provide emotional engagement. So it's okay to cry and to show your fear and to your anger, because nobody's looking at you and judging you. That person was crying in ceremony. And so the person's able to do that while aware of the symbolic nature of the experience. So there's not a lot of pointing of fingers going on. And what differentiates a ceremony and that kind of sharing from a debriefing after a traumatic incident is this aesthetic distance. So some of the studies have shown that after a significant trauma, if the people who are affected by it just to get together in a room and to go on and on ranting about the details of what happened, that can actually re-traumatize them a lot more than help them through their trauma. But what happens within this aesthetic distance of potentially of a ceremony and ritual is that the people are able to step outside of that left brain mode of going over and over the details of the incident. So just a couple of pictures of a powwow dance, and you can see the movement and kind of the trance state that this can potentially produce, both in the person who is participating and in the observer, just watching the colors and the movement and the aesthetic distance that it provides, and a structure of a sweat lodge. So to continue on, the significance for trauma healing is that because of the use of the expressive arts, the music and movement in a reverent state, ceremony and ritual can become kind of like a mindfulness practice that provides that relaxation response. And there's a lot of trauma that we have gone through, especially as children, that the emotions are really pre-verbal. So the nervous system was not developed enough for us to be able to explain all the horrible things that we've gone through. And those pre-verbal traumatic memories are much easier expressed through activities, through movement, through music, through sounds, through colors. And so the significance of what is potentially available in a ceremony and ritual is very significant for pre-verbal trauma states. It encourages a respectful expression, so people aren't taking their violence feelings onto themselves or to others in a ceremony setting, usually. And it normalizes people's response to trauma. So it's not, people don't feel shame as much when they're in that kind of ceremony because they feel connected to the others. They see others crying. They see others using their modes of expression. So it becomes less of a shame-promoting type of experience. It allows the community members to connect and identify with each other's pain. A lot of why trauma is so difficult to treat is that the amount of shame that the individual carries is so extreme that they feel like they're the only one. Nobody in the world would understand what they've been through. And for that reason, they're less likely to connect with others. But when they're in this ceremony space, they're more likely to see commonalities between themselves and others. And it allows for reframing, transforming, and recreating a new, more adaptive story, perhaps being able to connect with their strengths and the positive things that have come about from the difficult situation that they've gone through eventually. But that can only happen after the anger and the sadness and all the other stuff has had a chance to be expressed and to come out. So some of the research that's been done thus far, one is the work of Wilson and his colleagues in 1989, where they used the ceremonial fire and homecoming ceremony in Vietnam veterans. They looked at a natural hike for groups of veterans with post-traumatic stress disorder. They had a bonfire where there was a symbolic releasing of the individual's burden into the fire, basically freeing up of new energy and hope for the future. Then there was the Obenchain and Silver in 1992, who were concerned that a lot of ceremonies may be too odd or different for people who are not from the culture the ceremony is from. So they tried to look at a secular model of a ceremony in an inpatient PTSD unit. They used aspects of ceremony like award giving, honoring by a local newspaper editor, statements of appreciation from the staff of the inpatient unit, and followed by processing in group therapy. So there was a space held, there was kind of a ceremony, but it didn't have a specific cultural affiliation. And we actually use this model at our VA here in Tucson, where in the substance abuse treatment program there is a recognition ceremony for individuals with substance abuse, for example, where they can go through something like a ceremony to address their commonalities and deal with the stressors that come from having to go through a drug treatment program, for example. At the National Center for PTSD at Yale University in 2010, there was a hallmark study where they actually designed special ceremonies for PTSD patients. They had part of the ceremony be a tree planting where the veterans would actually symbolize this transformation of their identity as a wounded soldier and a wounded veteran through planting a tree and that notion of rebirth and reconnecting with nature. They used the sweat lodge and used that to symbolize the warrior identity being transformed into a human who's more nurturing and a mature, adapted person in society. They used this a model of self-disclosure while the participants were bonded with others in that collective pain. And they used this to establish a sense of individual and cultural continuity for these veterans. They actually used, it was a 27-bed inpatient unit, I believe, and they used 4 types of ceremonies. They started out with an opening ceremony where all the family members of each of the veterans came to the ceremony, and it was almost like it was for the start of this month-long or 3-month-long inpatient treatment program, and the purpose of the opening ceremony was for the families of the participants to basically allow them to go on this journey or to encourage them into their departure into this treatment program. And then they had a family night ceremony where the participants, who were all PTSD patients who were veterans, as a group would write letters asking for forgiveness to their families. And then the family members would write letters during the ceremony and read them out loud to their loved ones, and how hard it is for them to have them suffer as much as they are, whether with substance abuse or mental health problems. And then they had a crossing over ceremony at the end of the treatment session where, again, there was a meaningful, purposeful environment of returning the veterans to their families after they'd been through this pretty intensive treatment program. And then they also had a ceremony for the dead where they were able to honor survival and memories of those who had lost their lives in battle, as well as to honor the survival of those who had survived, even though they might have had lots of illnesses and trauma-related pain connected to their survival. And one of the methods they used to evaluate how this study did for the participants, they took the 61 veterans, and there's actually, I believe, 62 participants, but they got evaluations from 61 of them. And the 61 vets, their 25 family members, and 21 staff ranked the ceremonies as first in effectiveness. And the scale had to do with the ceremony, and then the other options were psychoeducation, group therapy, trauma work, individual psychotherapy, and medication. And those individuals ranked the ceremony as first for them in effectiveness. And then 100% of their family members, 92% of the veterans, and 87% of the staff rated the ceremony extremely helpful at the top of the 5-point Likert scale, which they were using to evaluate. There are also rehabilitative programs for survivors of torture, the use of a testimonial ceremony model, which was started in Chile in 1983, looking at a psychosocial model of treatment for torture survivors, channeling their anger into socially constructive action, and helping them give their testimonies in a ceremony format, but also have those testimonies become documents that would be used in the indictment against offenders. And they saw that it was really resulting in the alleviation of guilt of those people. Similar studies in Sri Lanka. In Denmark, they had a small pilot project. There was no control group, but they looked at 23 torture victims from India. And the ceremony they used was a combination of a mindfulness practice, giving testimony about the person suffering, and then a delivery ceremony where these testimonies were read in a public setting, another ceremony. And they saw a significant improvement in the World Health Organization 5 score. When they looked at a different type of scoring, less change was noticed, and it was thought that it was because of the poor culture specificity of that test. The participant survey, there was a unanimous satisfaction that the ceremonies were noted as a turning point in their healing process. And interestingly, 22 out of 23 participants went on to become involved in human rights movements, supporting other survivors, participating in demonstrations, and speaking about what they've been through at other community meetings. So last, I'd like to talk about some of the research challenges with looking at ceremony and ritual in the use of treatment of trauma spectrum disorders. One is that it's extremely difficult to assess efficacy. The standardization is not very helpful because ceremonies and ritual, their beauty and power, a lot of it is in the variety and the many forms, and it's very hard to make one ceremony good for everything or for various cultures. And then the fact that the evaluation tools that we have to use in other aspects of treatment are really not as useful across cultures, especially when you're looking at the differences of how trauma manifests depending on the person's cultural background. So what I'd like to see in the future is continued research using development of culture-specific post-trauma evaluation tools that are more meaningful when some of these studies are being done, examining the role of the tend-and-befriend response and the oxytocin, cortisol levels in participants in a ceremony, affected people's personal biases, their religious beliefs, their upbringings, their culture, and last but not least, what really is it that makes a ceremony effective for an individual? And with that, I'd like to conclude. Thank you very much, and I'm here for questions.
Question?
Yes, sir.
Was Dan in any way, the patient that you found first, was he in any way already in some way connected with, associated with, knowing about Indian culture?
I believe part of his challenge was that he'd become an alcoholic, and at an AA meeting he had met a friend who had some connection with this Native American community. And so at some point the friend had invited him and said, let's go try this. So Dan did not have any kind of a Native background. So
he wasn't
kind of
part
stepping out.
or anything like that.
Mm-hmm. He is now.